It's really a privilege for me to present these data on this phase 2 trial on behalf of the other site investigators, the other PIs, and of course the great team and scientists at GSK that have pulled this program together. The title is shown here, Safety and Immunogenicity of 3 formulations of an investigational RSV vaccine in healthy women 18 to 45 years of age, and it was phase 2. Nope. Got it. I think the background information is important to look at every single time, even though everyone in the room knows this stuff already, because it reminds us the why of what we're doing. Everybody knows what we're doing, at least to some degree. Everybody knows how we're doing it as far as moving forward for RSV prevention and treatment. But we have to keep reminding ourselves about why we're doing it. So please pause every once in a while and remove from that chaos of getting the work done and doing the what and the how, and just reflect a bit about why we're doing this. RSV-associated lower respiratory tract illness, major cause of morbidity in infants under 1 year of age. That's one group that's important to look at. And a large number of those RSV-related hospitalizations occur in the first few months of life. So it does make sense to work toward a program where passive transfer of maternal antibody is studied. We have proof of concept for influenza and for pertussis. So if we have the right vaccine formulation and we administer it the right way, this idea should work. The objective of this study, this phase 2, was to look at the safety and immunogenicity of 3 different formulations of GSK's investigational RSV vaccine, and this was in healthy, non-pregnant women. The endpoints were looking at reactogenicity of the formulations for the total vaccinated cohort, and the solicited adverse events were looked at for 7 days after the initial dose of the IP, and the unsolicited adverse events were tracked for 30 days. All serious adverse events were followed out to day 360, and at that point, the study was completed. The data I'm going to present today go through all of the information that's been evaluated and analyzed through day 90. The immunogenicity of the vaccine formulation is also important. This was looking at the day 90 according to the protocol immunogenicity cohort. The RSV neutralizing antibody titers were evaluated at baseline before the investigational vaccine was given, and then again on day 30, day 60, and day 90. Pelavisumab competing antibody concentrations were evaluated at those same time points. This pictorial demonstrates the study design, and the procedure is actually a very simple study design, randomized, observer blind, controlled in multiple countries. The target enrollment was 500 healthy non-pregnant women. Of the 507 enrolled, 500 actually received vaccine, and 454 were able to be analyzed according to protocol. For enrollment, subjects were randomized into 4 groups equally. The first group received a non-adjuvanted formulation of the vaccine with 30 micrograms of the F antigen. The second group received 60 micrograms in a non-adjuvanted formulation, and the third group received the 60 micrograms of the F antigen with an aluminum adjuvant. The fourth group was an active control vaccine group that received either DTPA or Tdap, depending on whether they were US or non-US. This is the diphtheria, tetanus, pertussis booster vaccine that's routinely recommended in many countries for all pregnant women. You can see that the vaccine itself was administered at day 0. Blood was taken for immunogenicity testing before the vaccine was given, and then again on day 30, 60, and 90. Solicited local and general adverse events are shown here. It's no surprise for those of you that do clinical vaccine trials that local injection site pain was the most common solicited adverse event. The grade 3 adverse events are shown in the red components of each of the histograms, and you can see that there was a suggestion there that the adjuvanted formulation was associated with a bit more pain than the other formulations. However, the adjuvanted 60 microgram formulation caused about the same amount of local injection site pain as the active vaccine control. Redness and swelling locally were grade 2 or lower and were infrequent. For general solicited adverse events, fatigue, GI symptoms, headache were all noted. Fever defined as greater than or equal to 37.5 is shown here on the slide. There was a single grade 2 fever in a subject, grade 2 being defined as 38.5 or higher Celsius. There were no grade 3 fevers described in the solicited adverse events for the first week after vaccine. Unsolicited AEs and serious adverse events are shown here. Again, the unsolicited AEs were tracked 30 days post-vaccine, and you can see were fairly equally distributed across the 4 vaccine groups. For related AEs, again, fairly equal distribution across the groups, grade 3 as well. There was a single grade 3 related AE in the 30 microgram cohort. For the SAEs up through day 90, you can see there was also a single SAE that was considered related by the local investigator. Neutralizing antibody titers are shown here. You can see that pre-vaccination, the neutralizing antibody geometric mean titers were very consistent across all 4 groups, and all women that were enrolled in the trial had detectable neutralizing antibody titers, a concentration of 1 to 8 or higher. By day 30, there was a approximately 3-fold or higher increase in the 3 RSV arms, but there was really no difference in the overall GMTs for those 3 groups. Looking at day 60 and day 90, you can appreciate there was an expected slow decay of the GMTs over time, but by day 90, the concentration, the GMTs were still twice as high or more compared to baseline. The geometric mean concentrations of the palivizumab competing antibodies are shown here, and a very important point is that prior to receiving the vaccine formulations, none of the groups had really high levels of detected palivizumab competing antibodies that were detected. By day 30, you can see there was a nice robust increase with up to 21-fold increase. But again, no substantial differences there between the 3 RSV containing antigen groups. Again, day 60 and day 90 shows the expected slow decay of the geometric mean concentrations over time. In conclusion, all 3 formulations of the investigational vaccine boosted pre-existing neutralizing titers 3-fold or more. The neutralizing GMTs were similar across the 3 RSV vaccine groups, and they waned over time but remained 2-fold or higher above baseline 90 days out. The palivizumab competing antibody geometric mean concentrations increased 14 to 21-fold 30 days post-vaccination. There were no safety concerns that precluded further development for any of the 3 vaccine formulations, although an exploratory safety analysis that was performed as a composite that looked specifically at any grade 2 or 3 adverse event, fever of 38.5 or higher, and or an SAE that was considered related to the vaccine. It was statistically increased reactogenicity in the 60 microgram adjuvanted formulation. Therefore, it was considered that the safety and immunogenicity data here supported the study and development of the non-adjuvanted RSV formulations in the upcoming studies during pregnancy. The disclosure slide is shown here. I'll speak to my own there in the middle. I received grants from GSK, both for clinical trial work and for translational work in my lab during the time this study was ongoing, and also have been doing clinical trials with several other companies that are interested in the RSV realm. Thank you very much.
Good morning. Very nice presentation. Did you see any impact of RSV season on your baseline titers in multi-country study? And we are not sure, since you said multi-country, which countries and which season it was conducted. But I think that will be important.
Yeah, so the overall concentrations of the RSV antibodies, either neutralizing or palivizumab competitors in the whole groups, did not vary across the three groups. I know for our study site, we were enrolling women January, February, March. So we were at peak of RSV season at our particular site, but I'm not sure where we were for the other 6 countries that were involved.
Greg Glenn, very nice study. I see it's a pre-fusion antigen. You could do a competitive ELISA against site 0, and were you able to do that? And then secondly, I didn't see, did you do RSV A and B or just RSV A newts?
The neutralization assays were done specifically using RSV A long. Site 0, I'm not sure if that was done as an exploratory analysis afterwards or not. I can check with the GSK scientists and get back.
My question is about the PCA assay. Based on the data, my assumption is the substrate for that assay was a post-fusion F molecule, looking at binding with or without palivizumab competition on post-F. Because we know if you use the pre-F conformation, there's a substantial amount of palivizumab competing antibody present in human sera. Mm-hmm. And so I guess the question is, how much fold rise do you think you would see if you were using the pre-fusion F molecule as the basis for the binding response? I think it would be more in the range of what you're seeing for newt activity, 3 to 4 fold rather than 20 fold.
So my understanding is the plates were coated with the recombinant formulation that was also used as the vaccine antigen. Okay. One of the struggles there is that despite a whole lot of effort, crystallization has been a major challenge. So it's not really clear where along that spectrum of true pre-F. It's somewhere in there. It's not. I don't think it's what we are now considering pure pre-F.
Okay.
Joe, thank you for such a nice presentation. I was wondering if you have, talking about reactogenicity and immunogenicity, if you could separate those or not. For instance, the women that had that fever and also mostly have the adjuvant, right? Mm-hmm. Do those women who have the adverse event are the ones that have higher antibody titers or not? Basically, immunogenicity and reactogenicity are together, or we can begin to separate them?
Yeah, well, that's a great point, because as a pediatrician, that's what I tell parents, right? If they have an artus reaction after their tetanus booster vaccine, I say, well, that means they're protected. They have a really nice cellular response. I'm not sure it's been analyzed to that extent yet, but that's a great point, Octavio. Thanks.
One more.
John DiVincenzo, University of Tennessee. So did you attempt to collect the data for the reasons why these subjects refused to participate in the trial, and to try to tease out what that would imply as to whether they would likely agree to have a vaccination during their pregnancy?
Not for this study. It wasn't part of the protocol, but we have been actively involved in an EPI study with GSK also. We enrolled 75 moms who were pregnant during the pregnancy. And in calling them back, we've started to ask them, you know, thinking back to when you said yes to do this, it's all just, you know, following you during your pregnancy, getting the cord blood when the baby's born, and then seeing when the incident RSV infection happens in your newborn. If we were having this discussion now and you were pregnant, since we have a vaccine study now, would you consider it? About 75%, maybe a little bit lower, are saying yes. But they're pre-selected, right? Because they're already sort of engaged and enthusiastic about being in a clinical vaccine or in a clinical trial. So I think we'll be able to find them.
Thank you very much.